Thanks very much for the introduction and nice to see everybody. I apologize I can't be there in person and I am excited to talk to you all today and look forward to catching up in person at future meetings. I'll be talking about vanishing white matter disease and it's a little bit hard for me to see folks here, but if there's questions, please speak up, or if there's any technical problems, just let me know as we're going along. So, just some disclosures today, nothing really relevant to what I'm talking about. We do have some clinical trials going on with vanishing white matter disease. So I think that's the only disclosure really relevant for this talk. So, vanishing white matter disease historically has had several other names that you might have run across. If you've looked in the literature, it used to also be known as childhood ataxia with CNS hypomyelination. And then it was also originally described in the French Canadian native population as Cree leukoencephalopathy. So, but it's all the same disease, same genes, and it's vanishing white matter disease. So this was one of the early patients that I met as a younger attending. So it was a 17-year-old young woman who was skateboarding, fell and seemed pretty dazed. They were worried about a concussion. And so she got taken into a local emergency department. At the time, she was in the emergency department, was back to her baseline, but just as part of the standard workup, they got a head CT because of the concerns about a concussion. So this is a picture of the head CT, and on the head CT, the radiologist kind of freaked out because there are these large areas where the white matter seemed really abnormal. So if you can see abnormal white matter on a head CT, that's a really bad sign. But of course, the young lady was sitting in the emergency room talking to the folks there, so it's kind of seemed very different for how she seemed to be acting versus what the head CT looked like. And that same day, because of the head CT being so normal, they got the brain MRI pictures. These were the brain MRI pictures, and they're quite abnormal. So I think the images on the right are kind of the easiest to see, where there's large areas of where the white matter is just like lost, so it's vanished, and hence that's where the name comes from. And the white matter also has this kind of a stranding appearance here, which is pretty characteristic, not purely for vanishing white matter disease, but is a thing you often see in vanishing white matter disease. So she had this very abnormal looking MRI, abnormal looking head CT, but was sitting in the emergency room doing fine. So this was a young lady who ultimately was diagnosed with vanishing white matter disease and is someone that we still follow at our hospital. She's doing well, and as I'll talk about later, she's involved in one of our clinical trials. And her presentation is pretty characteristic of how people sometimes present with vanishing white matter disease, just with kind of a relatively minor episode, whether it's illness or a fall coming in. Sometimes they're worse off than she was, but then the imaging can be quite dramatic. So vanishing white matter disease is genetic. It's a autosomal recessive condition, and is caused by mutations in one of five genes. These genes are the EF2B complex genes, and it leads to loss of the white matter. So hence the name. And so this was Dr. Vanderknap, who's really led the field in studying vanishing white matter disease, was one of the first to describe it and came up with the name. I think the MRI pictures here on the left, you can kind of see how what it looks like. So really, the on the top row is a person with vanishing white matter disease, and the bottom is a age match control. And this really bright white signal is the abnormal features of the white matter that's so characteristic, whereas it should really look kind of dark like this on the T2 images. And then as the disease progressions, there's areas where the white matter seems to dissolve away and possibly be replaced with spinal fluid. And these are these little patches, like right here or right down here, where the tissue has been lost. So these are some of the children that we have seen both at our center and other places with vanishing white matter disease. So we see kids and adults and young people of all ages with vanishing white matter disease. So definitely a disease that affects all the people that we love and care for. So it is a genetic disease. It's autosomal recessive, and the child can have the disease if both parents carry the mutation but aren't themselves affected. So if both parents are carriers, there's a 25% chance or a 1 in 4 chance that the child gets the disease. Again, it's these EF2B genes that are the cause of the disease. It's EF2B1, EF2B2, so E3 and 4 and 5. It's also possible that a person can develop the disease, what's called de novo or out of the blue, but that's more rare. So usually, if you find a person affected by the disease, it's likely that the parents are carriers. So again, the 5 subunits form a complex kind of glom together of something called EF2B. It's eukaryotic initiation factor 2B, and it's necessary for what's called translation, which makes proteins. And so for a long time, a lot of the work in the field really focused on EF2B's role in making proteins and trying to understand how when proteins synthesis was messed up that caused disease. But really the thing that came up in the past few years, oops, so we lost audio there. One of the thing that came up in the past 5 years was that the EF2B complex also controls something called the ISR, or the integrated stress response. So I'll talk more about the ISR here in a minute, but that's really been the advance in the field in about the past 5 years, understanding how EF2B controls the ISR. So molecularly, diagnosis usually is made by kind of clinical suspicion of a presentation, the MRI, but then you need a molecular or a genetic diagnosis to confirm it. You look for mutations in the EF2B 1 through 5 genes. Just in terms of nomenclature, the protein subunits are called alpha, beta, gamma, delta, and epsilon, but they refer to the genes EF2B 1 through 5. There are more mutations possible than have been seen in patients, so it's not clear. We kind of wonder if some of the submutations are too severe to be compatible with life. Some mutations are more common in patients. So, for example, the subunit EF2B5 is the most common cause that we see in patients, at least is what's been described so far. And then certain kinds of mutations are more severe. And so they're more severe in that the patient has symptoms earlier in life, like at a younger age, and that the disease gets worse faster. So, for example, the R195H mutation, which is in EF2B5, is associated with an earlier disease onset and a faster progression of disease. So just talking now about EF2B. So it's what's called a GEF, a guanine exchange factor, which is involved in this whole protein thing. So making translation, turning mRNA into proteins. And so EF2B is absolutely necessary for this. But in fact, the whole disease process really seems to be more its role in regulating the ISR, or integrated stress response. And so the ISR, the role of the ISR is when your cells are stressed, is to turn down or shut off normal translation, and instead to make the cell respond to stress by turning on certain other genes. So a bunch of genes and proteins get turned off, and then a subset of genes get turned on. So it's kind of like if you're in a city, there's an emergency, the fire department would be turned on, and they'd go out and like take care of the fires, but you would turn down a bunch of other services in the city. So you would shut off roads and stop traffic while the fire department goes out there and does its work. That's that's my analogy for the ISR. So so really kind of a hallmark feature and kind of almost like a thing that really should clue you in. Excuse me for thinking that you might be seeing a patient with vanishing right disease if they have kind of this um, abnormal kind of presentation. And so they often present with very catastrophic or devastating responses to relatively minor stressors. So things like fever, falling off a bike, skateboarding, like that first patient. Sometimes they're okay after the first presentation, but sometimes the first presentation can be very severe, and a person can end up in a coma after what seems like a pretty minor kind of incident. So with the ISR is absolutely necessary for normal function. So you need the fire department to be on, right? You need them around. And so if the ISR is too strong, cells get killed because having the ISR turned on all the time is bad. On the other hand, if you don't turn on the ISR, then the cell is not protected from the stress. And so there's kind of this kind of like absolutely correct, like golden area where you want the ISR to be able to be turned on, but also needs to turn off. And what happens in vanishing white matter disease is that the ISR is turned on all the time. So that's a bad thing. So the ISR is turned on by a whole bunch of different things. So for example, if you're oxygen depleted or glucose have hypoglycemia, low levels of glucose, that turns on the ISR. If you're exposed to like a sunburn or something that turns on the ISR. So there's different things that kind of activate the ISR that then is supposed to protect your cells. And again, as you mentioned, in vanishing white disease, the ISR gets chronically activated. So normally, EF2B is responsible for turning on translation under a stress condition. Normal translation gets turned off, and you turn on the ISR, and then there's a way that you kind of turn off the whole system, turn off the ISR, and get back to normal translation. So that's the normal situation. However, in folks who have vanishing white matter disease, EF2B is mutated, and so normal translation is messed up, and the ISR gets turned on abnormally. And then, in fact, because the ISR gets turned on abnormally, it's hard for itself to get turned off. So there's actually kind of the whole regulation system for turning off the ISR is messed up in vanishing white matter disease. So when we have someone that we're concerned might have vanishing white matter disease, of course, there's the clinical presentation to make you think about it. They'll have imaging that's suggestive of it, but then they need genetic testing to confirm the diagnosis. And so there's a variety of different choices now that are available for clinicians to make a diagnosis. This includes leukodystrophy gene panels, exome sequencing or genome sequencing. I think that in general, it's better, unless you're just confirming a known diagnosis, to send off either a panel, exome, or genome to look for the mutation. So the one big question we often run into is trying to figure out how common is vanishing white matter disease. So there's a broad range of of uh, predictions for how common it is, ranging from about 1 in 80,000 births to 1 in a million live births. So work in 2018 from the group in Amsterdam had a prediction of approximately 1 in 80,000 live births, whereas a group in the United Kingdom in 2016 predicted about 1 in more than a million live births. So that's a very big range. You know, if you're thinking that it's like 1 in 50,000 or 1 in 80,000 live births, we would predict that, for example, in Utah, we'd see about 1 patient a year, 1 new patient a year, or 6 in California, or 4 in New York State, sort of based on number of patients being born. We did a project a few years ago trying to get a better sense of how common it is. We used a database called Nomad, which has a list of all the known human mutations. And you can basically use a statistical method called the Hardy-Weinberger equation, excuse me, to try and figure out how common you would kind of predict vanishing white matter disease to be. And so we used that and looked at all the different known mutations of vanishing white matter disease, as well as mutations that weren't even known. And this is kind of a bunch of the information where it confirmed that EF2B5 was the most common subunit affected. And we looked both at variants that were clinically verified, meaning that we knew that patients had them. We also looked at variants that had never been seen before in a patient, but at least in these databases had been seen. So we did it kind of both ways to check. So using this approach, we came up with an incidence of about 1 in a million. So that's lower than some predictions, but more in line with what they had seen in the United Kingdom. Of course, the database that we used is something called Nomad. It is very heavily kind of biased toward Northern European, Caucasian patients, and so it's possible that we're missing understanding like large segments of the US population, as of course, as well as the world population. Also, the incidence of 1 in a million seems low compared to at least what we're seeing locally. So I think you have to take this incidence determination with a grain of salt. So vanishing white matter disease can affect folks of any age. Uh, we have folks who've been affected before birth, infants, toddlers, children, teenagers, and adults, and so people can present at any age. There's also kind of this question in the field whether you can be asymptomatic, and I think that's still out for discussion because it's clear, for example, that we can make a molecular diagnosis before we see at least clinical symptoms. But of course, I'm not sure. I at least personally, I don't think we've done really a careful study to look at like what people's MRIs look at before we know if they're affected clinically or not. So I think that's an important question in the field as we kind of try and understand when does the disease really start affecting people. So vanishing white matter disease has a broad, is a demyelinating disease. So there's loss of white matter, affects how the central nervous system functions. And the symptoms really depend on the age of onset as well as what part of the brain is affected. Um, the disease tends to be progressive and worse. It does have these kind of episodic worsenings. Often, though, after a worsening, people get better. But in general, the overall trend of symptoms is to slowly get worse. So this includes things like loss of developmental milestones, spasticity or tightness. In the most severe cases, people are getting lethargy or coma. Some patients particularly are affected by seizures. There can be loss of ability to like walk or to crawl. Oftentimes there's impairment in kind of cognitive function. For some patients, depression, anxiety, and other kind of psychiatric symptoms can be quite severe. And of course, in the worst, as disease progresses, in the worst cases, it can lead to death. So this was a nice group of work from the Amsterdam group in 2018, where they looked at the age of onset for a large group of patients. And so this shows that the largest group of patients were affected in the first kind of 5 to 8 years of life down here at the left. But you can also see that patients continue to kind of show for the first time, into their sixth decade of life. So really a big range of when people first showed up. Because of these different ages of onset, there's a broad range of symptoms. And so the different ages of onset tend to be kind of associated with certain kinds of symptoms. So the antenatal onset tends to be the most severe, often dying either with still like having a stillbirth or dying in the first weeks to year of life. People who have infant onset, so in the first year of life, that tends to be the most severe form of vanishing white matter disease that we see, and really progresses rapidly in a quite severe fashion. And then it kind of, as you look at these later ages of onset, the symptoms are less severe with a slower rate of progression. So I think a nice way to kind of look at these descriptions is in these graphs from that 2018 paper. So the left-hand graph looks at how many people are surviving based on their age, and then the right-hand graph just shows like how long they've had the disease. But if you look at the left-hand graph, the black line is people whose disease started affecting them when they were less than a year of age, and you can see that the majority of people who are affected in the first year of life die by the time they reach 5 years of life. And really, the majority even die like kind of in the first year or two. Whereas if you're on this green line, which is someone who has a disease presentation when they're older than 18 years of age, the rate of death is much slower. And so the majority of people live up into their 60s or later with disease. And so this is true not only for the survival, but it's also true for the amount of disability that people have. So the younger you are with the first presentation, the faster the disease gets worse and the more severe it is. So again, just as a reminder, so when people come in and there's concern, brain MRI, of course, can be very suggestive, but really you need that genetic testing to identify the gene mutations and can confirm it, because there are mimics or things that you can be tricked about for being concerned for the disease. So just to remind ourselves about the imaging, the T2 signal shown here on the left MRI is a super bright, very abnormal looking MRI. It's like super dramatic. You're like, whoa, like it's like a very impressive looking MRI. And then on the T1 image, there's areas where you seem to be losing white matter. So this is kind of the vanishing part that you see, and these kind of stranding inside of the lost white matter. That's I think that's pretty characteristic, but not pure, not just in vanishing white matter disease, but is often seen in vanishing white matter disease. So we don't currently have newborn screening for vanishing white matter disease. It's not currently on the RUSP. I think in the next 5 years, as I'll talk about later, that we have several therapies kind of in the pipeline that I'm pretty bullish on. So I think that we would be something that we'd be thinking about in the not too distant future. So are there treatments? So currently there is not a cure, but of course there are symptoms that can be treated and managed, and that really makes a big difference for patients and their families. There's also a lot of discussion around supportive care and preventive care. And as I mentioned in a minute, there are kind of guidelines and suggestions coming about this, but the level of evidence that we have is pretty minimal. So I think that it's good to be cautious and thoughtful about how we take care of people, but it's also good not to have a phobia or over fear about things for treating patients. So the issues for management are pretty standard that we see for vanishing white matter disease, as we see with other leukodystrophies or other complex medical conditions. So there's seizures, which can be difficult in some patients to manage, the problems with spasticity, ataxia or what's called imbalance can be quite a big problem for many patients with vanishing white matter disease. For prevention, there's pretty standard stuff that are well accepted. So making sure you get vaccines, and then avoiding kind of obvious sources of head trauma. So, you wouldn't want someone playing like tackle football or and the whole vaccine discussion also, like, of course, we always worry that giving a vaccine might cause some stress, and would that be like a cause of, precipitate an episode in vanishing white matter disease? But on the other hand, if you get the flu, like that is much worse than like getting the vaccine. So like we really, in general, encourage getting vaccines if it's tolerated by the patient. So symptom management is kind of very standard for what we do kind of across different leukodystrophies, really encouraging maintaining as much motor function as possible, like with physical and occupational therapy, treating spasticity, making sure that we keep an eye on swallowing and oxygen status if people are having problems with respiratory issues. Seizures in a subset of patients do seem to be very problematic. And it does seem to be, again, we don't have great data on this, that seizures, for people who have seizures, that if they're not well controlled, that it can be that it's bad for patients. So I really encourage keeping a close eye on seizures. And then in some patients, particularly those affected with more severe forms, I think feeding tubes, although often families, it can be kind of a scary thing to think about feeding tube. I think it can make life a lot easier, both for the kid and for the family. So what are the current treatment recommendations? So there's a nice set of consensus guidelines coming out for something called the Vanishing White Matter Consortium, and I'm hoping those will be out maybe later this year. But kind of these are, common sense things. So avoiding illness and stressors as much as possible, but again, also living your life. So I think that we're trying to balance recommendations that, don't do foolish things like playing football or exposing yourself to people who are sick. But on the other hand, like, don't be afraid to go out shopping with your kid. Again, encouraging vaccination, because getting the illness is much worse than dealing with the problems of the vaccine. We've also tried to compile a list of medicines that might be better or worse because of their known role affecting the ISR, that thing, the integrated stress response. And then there's kind of, I think the experts in the field kind of debate a little bit about whether or not, like, how aggressively to use antibiotics or steroids in cases of illness. Um, Antibiotics, if it's a viral infection, of course, aren't going to help, but maybe it's better to be careful when you're first showing signs of sickness. I think the jury's still out, so just so you're aware that that's kind of an active area of discussion. There are a bunch of different groups that are involved with vanishing white matter disease, including, of course, our illustrious colleagues here with Hunter's Hope, the Lucas V. Care Network. Um, the Vanishing White Matter Families Foundation and Vanishing White Matter Foundation came together kind of a couple years ago to work kind of across the US. So I think that's been nice to see. The ULF, United Leukodystrophy Foundation, of course, does a nice job as kind of a central warehouse for all things leukodystrophy. And then finally, the Vanishing White Matter Consortium is very much kind of professionally focused, but I think has also done a great job kind of moving the field forward in terms of recommendations and making suggestions for clinical trials. So when we first see patients in clinic, I think that the information on the internet is quite concerning. And so I think that in general, the prognosis is better by and large than what's kind of out there on the internet. Um, Survival and disease complications, of course, again, really depend on the age of onset and related to certain genotypes. But particularly when I'm first seeing people trying to really um, be encouraging and take the stress level down some. Um, there are several big efforts currently to understand natural history. There's already been that very nice work from the Amsterdam group published in 2018. So the Vanishing White Matter Consortium and the Amsterdam group continue to collect natural history. So if you have patients, we certainly encourage them to get in contact because I think that natural history information has been very important for us understanding disease progression. Also, GLIA, the Global Leukodystrophy Initiative, which has about 8 sites across the United States, has been collecting information on VWM patients. Again, also an important opportunity to participate and kind of help the community out with understanding VWM. So there are several clinical trials underway. There's been a clinical trial in Amsterdam led by Dr. Van der Knap on medicine called guanabens. Guanabens was developed as an anti-hypertension medicine, but is not used for that anymore. And so work from her group had shown that it seemed to help mice with vanishing white matter disease. And so now we're several years into the trial. The details are a little bit unclear, I think, about enrollment, but the but enrollment does seem to be full, and the criteria is onset of disease before age 6. There are no published results yet. I think that the kind of the word of mouth out there is that it's kind of unclear, I'd say, would be my take on the current trial with guanabens. There's also a trial that I'm involved in, so just be aware that I'm involved in this trial. It's from Calico and AbbVie. The medicine now has a name. It used to have just a code number, Fosgitafator, I think is how it's pronounced. I'm not really sure. So it's a quite small trial. It opened here at Utah with just 4 participants, and then it's very slowly expanding. I think that we're waiting currently for Amsterdam and Boston to open up, and then I think Calico and AbbVie have been talking about other sites worldwide as well. I'll talk about it a little bit more in a minute. And then finally, a company called Prilenia has a medicine called pridopidine that's been developed. And I think it's being used in a couple folks kind of in a compassionate use or IND type fashion. And I haven't really heard anything one way or the other about how that's going. There's also lots of research going on, which I'll kind of at the clinical level. There's also, of course, basic science research, but from clinical research, there has been work in gene therapy, and that's been mostly work from ourselves and Dr. Bradbury collaborating between Nationwide and Utah to do replacement gene therapy. I'll talk a little bit more about that. There's also been work on what's called base editing, and that's been led out of the Amsterdam group with Dr. Vanderknapt, and in Zurich. And that looks, so it's still kind of in proof of concept phase. There were some attempts at using CRISPR, again, from the Amsterdam group, that didn't seem so promising. And I think I'm aware of at least one group that's working on small molecule drug screening for vanishing red matter disease. So one of the confusing things with vanishing red matter disease is that the protein, this EF2B protein, is expressed in every cell in the body, but really it's the symptoms in the brain that are most devastating. So trying to understand like what cells in the brain are affected, why is it so like severe for the brain, and then also why is there this kind of like toxic response in the myelin? So it seems like there's actually like something kind of toxic killing off the cells. So it's been kind of a confusing disease to understand. So there's been a lot of work developing model systems to study this. So this includes developing cell lines. So this is a bunch of different groups have developed cell lines. There's also been mouse models, multiple mouse models developed, and finally like also the zebrafish model. So lots of like basic science in trying to study the disease. I think the most important major step, other than first understanding that it was the ISR that was really a key player, was then also seeing that it's the astrocytes, which are kind of a group of what are called glia inside the central nervous system that are seen to be like the key cell type that are affected. And so there are a couple big papers about 6 or 7 years ago now that showed that it was the astrocytes that were a key cell associated with disease pathology. So I think that's really helped the field move forward. Two of the mouse models that have been used to study them, one is they're both, and there are other mouse models as well, but these two have been the most important, I think, for the research. One is the R191H model, which is the same as the human mutation R195H, which I said is a really severe form of disease in humans. And then there's also a new mouse model that kind of they found spontaneously. And the advantage of it's the I98M mouse, is that its symptoms start even earlier. So its symptoms start by 2 to 3 months of age, whereas the R191H mouse doesn't develop symptoms until 6 months of age. And the reason that matters is because if you're trying to study something and you have to wait 6 months for something to happen, then like you're really not doing anything for 6 months while you wait for the mouse to get sick. So the earlier and more severe the phenotype is, the easier it is to do experiments. So the mice models, the problems that you see is that they have failure to thrive. So they have low weights. They develop motor dysfunction. So they feel something called a rotor rod. I'll show you a video here, I think, in a little bit. And then they have abnormal white matter and they have activation of the ISR. So they basically have the same symptoms, at least the mouse equivalents of the same symptoms that human patients do. So on the right are bar graphs showing that by 6 months of age, the mice fall off the rotor rod. And so this is what it looks like when you put the mice on a rotor rod. So this is a rod, and a normal mouse can kind of stay on it for a while as you kind of speed it up, whereas the mice with vanishing artery disease fall off faster. And so you can see they can keep on and whoa, they fall off. So that's the rotor rod test that we use to test motor function. There's other motor tests as well, but that's the one we use most commonly. So there's loss to the white matter. So you can just see a normal dark blue appearance of the white matter staining the brain, whereas the mutants, the white matter, it's hard to see here, but it's thinner, the whole area, and there's less of it. And then the red bars compared to black bars show that a whole bunch of different genes involved in the ISR are way upregulated in the mutants, in the brains of the mutants. So, so the approach that we took for trying to develop a therapy was to use something called gene therapy, where you basically take the normal copy of the gene and are giving it back. In this case, we're testing it first in mice, but with the eventual goal that you would deliver it in human patients. And so the way we did this, and this is work from our group in Utah together with Allison Bradbury's group at Nationwide Children's Hospital, was to take the wild type copy of the gene. In this case, we were only working with EF2B5 since it's the most common human mutation. And we wanted to express it in astrocytes, since we had talked a little bit just now about how astrocytes seem to be the key cell that are affected. So we are infecting the brain, and then we're trying to express the wild type gene in the astrocytes using what are called different promoters to reach those astrocytes. And to do this, we inject the construct, the virus construct, right directly into the brain. We inject into the ventricles, into the CSF space in the brain. So that's called ICV delivery, intracerebral ventricular delivery of the virus. And so we tested a variety of different constructs. And so this is kind of a summary of the data looking at the rotarod. And so at 6 months of age, wild type mice shown here in white, you can speed up the rotarod to close to 30 rotations per minute and they stay on, whereas the mutant mice fall off at a speed of about 10. And some of our constructs shown here in blue and green, those mice were essentially exactly the same as the wild type mice. We're like, yay, we've got a construct that works. Unfortunately, over time, the how well that construct seemed to work fell off, so that by 9 or 10 months of age, it's still better than mutants, but it's only about a 50% rescue. So 50%, that's good, but of course, before we go to a human patient, we'd really like something that works better. And so the motor dysfunction, other aspects seem to be really rescued, but it's only a partial rescue. So we've done a bunch of work now to try and like get a better rescue. So we used a new promoter because we were worried that maybe the promoter that we had, maybe it wasn't continuing to express strong enough. So we tested a new promoter, and that's kind of these yellow bars shown here. And the yellow bars, it's better than the, it's a better rescue, but it's still not as, by 8 months of age, shown here, it's close to wild type, but it's already starting to fall off a little bit. So again, it's better, but still not perfect. We've done things to look at like, can we get this even better? So we've looked at expression levels in the brain, and the promoter does seem to be expressing one in the brain. We've also looked at expression in the spinal cord, because not only is the brain affected, but the spinal cord is affected. And we are getting good expression in the spinal cord. So we are trying a couple of things to see if we can kind of improve this. So we've tried different areas of injection. We've tried different doses. We've also tried to see whether or not a different cell type called the microglia involved, because maybe it's not just astrocytes, but also microglia. So on the one hand, we're very encouraged that we're seeing partial rescue, particularly with this newer construct. And now we want to, before we go into clinical trials, we do want to make it work as well as possible. The hope is that we could, in the next year or so, that we'll have good enough results in mice that we could then talk to the FDA about filing for an IND and taking it into clinical trials. And of course, if we can do this with EF2B5, the most common subunit, can we then progress and do it with the other subunits as well? So really just to kind of conclude this part of the talk, we have this astrocyte targeted gene therapy, we have partial rescue, and now we're trying to get the quote unquote ideal rescue. So I'll wrap up here with the last maybe 5 minutes or so talking about the clinical trial that we've been involved in. It's a phase 1B, and it's been mostly ourselves and then the group in Amsterdam, Dr. Vanderkamp, who's really worked with Calico to develop this trial. So just to remind everybody, there's different phases when we move from an idea in science to a drug and treatment of patients. And so the first phase is here just in the lab, trying to understand how disease works. And so that's really important. T1 or phase 1 trials is where you first kind of see, does the drug or your treatment do anything? In phase 2 trials, you're kind of testing to see if it's working in patients. And then phase 3, you're really studying how effective it is. And then, of course, in the community, you kind of look across population health. And so these different phases of the trial are very important. You want to kind of move stepwise from one to the other. But of course, in rare diseases, whether it's vanishing rare disease, Krabbe disease, or any of these rare diseases, it's hard because there's so few patients. So it's really hard to, of course, see if you're to kind of get statistical numbers that you can understand. But on the other hand, it's also hard because because the diseases are progressing, is it really fair to give someone a placebo? So there's kind of problems that we all encounter doing these kinds of clinical trials. So I'll just skip this slide. So the phase 1b trial, the way it works is we assess someone, kind of do a pre-assessment preparation. At the initial visit, we do an exam, we do baseline blood draws, a lumbar puncture, an MRI. We give the drug and make sure they don't have like some sort of weird reaction to it. And then over the next 2 years, we do kind of the same thing at kind of longer and longer intervals. It's a very complicated process to set these clinical trials. The amount of paperwork and regulations is just immense. It just gives me like a migraine to think about it. And then it is also, of course, not only a major time commitment from the physician and study team, but the patients and families. You're coming in for a day or two at a time. Oftentimes you're spending the entire day there. If you have to travel, you add that travel time. So it is, on the one hand, like a chance to be have an early opportunity to get treatments, but on the other hand, it's not known for sure if the treatment works, and it does take a lot of time to be involved. The drug that's being trialed is something called an ISR inhibitor, so trying to turn down the ISR. It works by stabilizing the EF2B complexes, which in the mutations seem to fall apart. And at least in like mice, the ISR gets turned down and normal protein synthesis is happening. And it seems to work maybe broadly across, regardless of what the mutation type is, which is appealing. So there's been a whole bunch of kind of basic science work leading up to using this set of compounds, and they've kind of now they kind of started with like most basic form of istrib, and now it's been kind of like modified for human use. And so the compound that's being used in clinical trials is called ABBV7262, and now it's got a name, fosgitafator. It's an oral medicine. It's solid. It basically looks like kind of like Pop Rocks. Unfortunately, it doesn't taste that way, but it looks like Pop Rocks, and it is water soluble. So how's it going? So we're in the middle of the clinical trial, so I can't actually like say anything really, but so far so good. So thumbs up for that. So it seems quite promising. The process of doing a clinical trial with a new drug in a disease that hasn't really had clinical trials before has been quite complex. So like lots of issues to figure out. Again, just it looks like Pop Rocks has been the most exciting thing for patients and families. Probably the most daunting thing has been concerns about doing the lumbar puncture. The lumbar puncture is where the spinal fluid is analyzed to see what the levels of the drug in the spinal fluid are. So it's for the research team, it's very important because that's how they're assessing how much of the drug is reaching the brain and how well the ISR is being turned off. But for patients and families, it's kind of scary. But for the participants, we've talked to them about it, and they've said that, oh yeah, they were quite concerned, but then with the LP, it's been totally fine. So just to kind of summarize, the phase 1b is underway. It's been adults only. It only had 4 participants, so very, very small. And so we're now in kind of year 1 of 2 of the study. The phase 1b/2 has started. It's ages 6 through adulthood. We've enrolled our first patient and are hoping to enroll our next patient soon. And then that's just at the Utah site. We're hoping that the Amsterdam site and the Boston sites will also open. And then Calico is working on what's called a phase 2/3, so kind of even expanding it more. And that will even be for younger ages. The phase 1b/2 continues to be quite small enrollment. So worldwide, it's predicted to be about 10 to 12 patients, which is just a very small number of people. So, so it's been quite, I think it's frustrating for families, understandably. And it's, of course, we don't really have control over it. I think it's just trying to be as careful as we can as we roll this out. It's been a real process, a lot of work on different people's part, including ourselves, the Amsterdam Group, Calico, the VWM Consortium, the families who are doing this. So I appreciate everybody's patience, so to speak, with as we as it gets rolled out. So just to summarize, the thing, like if you can only remember 4 things from today or from this talk, so VDMA can be misdiagnosed or missed. So just have it on your radar if a patient comes in. Be aware that the MRI often looks much worse than the patient does, so don't be too freaked out by the MRI. I think it's important that if you find one person affected in the family, that you check the other kids who could be at risk. And then diagnosis is important because clinical trials are here, and I think that we're hopefully entering a new era for what we can do. So thanks for your attention. I probably ran over a little bit, but I appreciate the chance to talk to everybody.